Nick. There's nothing that changes a surgeon's behavior like knowledge of anatomy. And that's because everything we do is trying to recreate, reestablish normal anatomy if we're doing it in the operating room. And of course, anatomy is completely important outside the operating room. Physical exam of the elbow is similar to the shoulder in that there's features of the elbow on MRI that are abnormal but may not be the patient's or the player's problem. And there's also things that don't get picked up on the MRI. So exam is extremely important. Here's a reference for you if you want to look at this in more detail. And this is the strategy. Everybody can develop their own strategy, so this is just one. If you divide the elbow up into 4 compartments, then you can sequentially examine each compartment. So we'll go through the anterior, lateral, posterior, and then the medial. First, this is an exit physical on a professional athlete. The first thing to recognize is motion limitation is normal sometimes for these throwers. This is how he lives. He's not having any symptoms, but you can see he lacks flexion and extension. What may be important is the progression and motion changes. So there will be motion abnormalities, or maybe they're just normal for that particular throwing athlete. Here's the anterior elbow. This is the area that I like the least. We're going to get it out of the way right now because these diagnoses are a little elusive. In the anterior part of the elbow, it could be related to the bone, the humerus, stress reaction, something like that. Biceps tendonitis, not that common actually. It's usually related to weightlifting, not the throwing motion. But then you get these other nerve or vascular mediated things that Tony explained to us, thoracic outlet type syndrome, or this median nerve that we'll show you. This is a case from this year. Player says, my elbow and arm is it's getting tight and it's getting harder to loosen up. And in fact, it's big. You may not be appreciating, but he's right-handed. His right arm is much bigger than his left arm from about the deltoid down. He's got a big fat hand compared to the other side. It may not look that impressive on the photo, but this hand is big. This guy's got a thoracic outlet problem. He went straight to the hospital. I saw him. He thought he was just passing by. I said, you have your toothbrush with you? You're going to the hospital. Vascular exam, started anticoagulation, all the things that Tony spoke about yesterday. Here's another elusive diagnosis that is picked up on physical exam. It was John Conway who showed me this. You can palpate the median nerve and you can palpate the humerus. So we have the patient lying. We palpated the humerus. If you go anterior to the humerus and just medial to the brachialis, if you want to do it to yourself, keep poking until you find the rope that makes your fingers tingle in your middle finger. You can palpate the median nerve. And patients or players that say it hurts in the front, if you reproduce it by direct palpation to the median nerve, it's likely that they're having a median nerve entrapment issue that's causing the pain. This kid's undiagnosed for 2 years. He can't throw for 2 years. He says it hurts right here every time he tries to throw. It happens after a period of time. This could be thoracic outlet. It could be a cervical thing. But because his exam is so consistent with it, we elect to do a median nerve decompression. And this kid is corrected in about 3 weeks. He says, I'm cured of this. It's a physical exam. All right, here's the biceps. In the front of the elbow, not that common. You can palpate the biceps. You can do this hook test. Not that common in baseball players for them to have ruptured their biceps, but if it's ruptured, you put them in this position of abduction, hold their thumb up, have them resist. You can hook their biceps going from lateral to medial. As opposed to this, you can tell his biceps is ruptured. It's approximately migrated here. You can't hook anything. Positive test. More common is they have biceps tendonitis. And actually the best exam is you have them in full extension, ask them to flex, and you resist them, and you'll say it hurts right there in the front at the biceps. Okay, let's move to lateral. We'll see some of this stuff in our throwing athletes. This is an exam for epicondylitis. You palpate the extensor muscle mass insertion, right where they say it hurts. And if it's tender there, you're getting a very strong clue that it's lateral epicondylitis. You can also palpate down here by the PIN, see if they have PIN-related symptoms which could coexist. And then we're going to stress the tendon. Elbow in full extension, have them resist wrist extension and finger extension, and they'll say it hurts right here at the extensor mass insertion. It's the radial capitellar joint, where you can assess for a plica or crepitus. So you pronate the hand, move them into flexion, and you may feel and palpate a pop. I'm going to turn the volume up on this. You can hear this better than you can see it. But look, he's in pronation. Look right here. Yeah, he's snapping a plica. Physical exam gets that. You'll see plica on every MRI scan, but it's the physical exam that tells you that it's hurting. Let's move to the back of the elbow. Triceps is in the back. Triceps tendonitis in a thrower, whenever I hear that, my radar goes up that it's probably not triceps. It's probably a olecranon, or it's an osteophyte or loose body, but they say it hurts here, and they say it hurts to extend, so we jump to this triceps tendonitis conclusion. So more commonly, it's the posterior medial olecranon, which you can palpate. If it hurts there, that's a clue. And then you can do this, and John's going to explain it to us more. But if he's got this in the back of his elbow, a cracked osteophyte, he lets you do it once. He won't let you do it more than once. It hurts. Bounce him into full extension. This is an armbar test. Here's an example of olecranon stress fracture. You put him in position, and then you put sustained stress like this. That will put stress on their olecranon stress fracture, and that will elicit the symptoms. Sometimes this chondromalacia in the posterior medial articulation of the ulnohumeral joint, you can elicit symptoms with this same maneuver, which we'll go in more detail, the moving valgus stress test, but it's going to be towards extension. So we're going to stress the elbow, and towards extension, if it's medial pain, it'll be more likely cartilage than if it's in this zone between 70 and 120, which is probably the ligament. We can check the flexor pronator mass. There's an MRI scan of a flexor that was damaged. You can palpate it, and then you could do resistance testing, flexion of the elbow, flexion of the fingers, and you can have them resist pronation. Okay, here's where the medial elbow is. Save the best for last. This is where we're going to see most of the pathology. We can palpate not just the ligament, but we can palpate the medial epicondyle. We can work down the ligament and palpate the ligament. We can even palpate the sublime tubercle. And we can start to differentiate where the pain or the symptoms are coming from. This is valgus instability. We often say, hey, the guy's a little unstable. I've never met a pitcher with a ligament tear that's actually been unstable yet. Tommy John's elbow is unstable, but it's usually very subtle laxity on the order of millimeters, so it's hard to appreciate. This happens to be one where he tore his flexor pronator mass as well as his ligament, so you could appreciate the valgus instability there. But this is the hallmark test. This is the moving valgus stress test. Grab his forearm or his thumb, stabilize the elbow, move them in flexion extension with valgus, and see if it elicits pain over the ligament. I'm evolving my physical exam. I work on my exam all the time. I like doing it now with the patient lying down. The reason is the humerus is so stable here. The patient is relaxed. It's easier for mom to be on this side and dad to be on this side. And then we can palpate the epicondyle. You can see it there, the ligament, the sublime tubercle. And look how stable we have the humerus here. And he's relaxed. And now we can do a moving valgus stress test. We can even do the bounce test with checking the posterior olecranon. Terrific. Okay, let's move on to, John's going to talk about ulnar nerve. So I'm not going to spend a lot of time. I'm just going to show you some highlights. Most common time I see ulnar nerve symptoms, tingling in fourth and fifth digit, is the guy all of a sudden is lifting like crazy and he's a thrower, and this thing gets big. Triceps gets big, and then it's kind of pushing and creating within the cubital tunnel compression. This kid said, I was throwing one day and I felt a pop. Well, that doesn't sound good. He felt a pop. You don't see this easily on an MRI. If he gets his MRI in full extension, this thing that's popping is it's located. This is his ulnar nerve popping over his medial epicondyle. He's got a subluxing ulnar nerve. Here's a patient who had a pop and thought to be a subluxing ulnar nerve, and he had surgery. And his nerve is now transposed, and it's stable in a transposed position. So what is popping? This is actually his triceps. Medial head of triceps is popping. So something to keep in mind, the triceps can pop also, and then you have to remove and reroute some parts of the medial aspect of the triceps. Okay, I'm going to jump over this because John's going to go over some ulnar nerve exam stuff. I use the ultrasound sometimes, but I'm just going to highlight this. This kid had surgery 8 months ago, and he says, I'm dropping things, my hand is weak, and I'm continuing to do my therapy, but it's not going well. Look at how much atrophy he has in his hand. And so he's got ulnar nerve neuropathy now, and he's got intrinsic muscle wasting, and he's got extreme weakness in this hand compared to this hand, to abduction, adduction, even flexion at this point. Something that we don't talk about a lot, I thought I would just show one example is, this kid had Tommy John surgery, fantastic. Well, how do you examine an elbow after Tommy John surgery to make sure they're ready to progress, throwing, all that kind of stuff? Well, we'll do all the same stuff. Lie him down, bounce him around, see if the back of his elbow is okay, push on that posterior olecranon, make sure that's okay, and then we're going to push on his ligament reconstruction. Yeah, magic. And then we'll stress him. Elbow exam's good, you're ready to start throwing. Terrific, thank you so much.